All right, party people, we are back at it with another one. Let's get it. So we have a 50-something-year-old dude with pain and numbness in his hand. His peripheral pulses are normal. On cardiac exam, he has a mid-systolic click. Platelet count is 1,500,000. Neutrophils are 69%. And we have this hand. You can see the discoloration. Now I'm asking you, what is the diagnosis? All right, let's go over why the correct is correct and why the incorrects are incorrect. First and foremost, let's just get through the whole concept of this mid-systolic click. This is mitral valve prolapse. However, in this case, this is a completely benign incidental finding. So I want you to forget about it. Your licensing exams will sometimes do this. Do not freak out. They like to do this especially on site questions. Just keep that in mind. They like to use this on panic attack type questions. They'll toss in an MVP click just to throw you off. So again, keep that in mind. Now, the photo of the hand shows a red erythematous hand. This is erythromelalgia. Erythro meaning red, melalgia meaning pain. So, aka a painful red hand. Now, it's seen in a few conditions that you're going to have to know. So let's run through those. In Raynaud's phenomenon, this is associated with CREST, all right, and systemic sclerosis. It's also included Waldenstrom macroglobulinemia. It's not the diagnosis here, but it's worth noting. It can also be seen in myeloproliferative disorders. Now, as far as this platelet count, this is absurdly elevated. It's extremely elevated. Normal is 150 to 450K. We're at triple that. Also, the neutrophils are elevated. Normal range is 55 to 60. So this is a left shift, which usually suggests bacterial infection. Everything else is normal. So let's move on. We got normal vitals, normal WBC, neutrophil predominant shift, very high platelet count, and a painful red hand. Let's run through it. So AML is wrong. AML would have blasts. You would be told explicitly like something in the range of 20% blast. Or you would get a smear showing our rods. These are from myeloperoxidase in myeloid lineage blasts. Typically, this also presents with leukocytosis, sometimes extremely elevated, sometimes as high as 200,000 white blood cells. Now, not all AML cases show elevated white blood cells, but most do. Therefore, no blasts, no hour rods, WBC is normal. It is not AML. Moving on. Next up, CML, also incorrect. CML shows metamyelocytes, myelocytes, and promyelocytes on the smear. Now, this is associated with translocation 922, which is associated with BCR-ABL. You treat this with imatinib. This is a BCR-ABL tyrosine kinase inhibitor. You have to remember that the side effect of this drug is fluid retention. Again, none of this is present in this patient. The platelets are high, but cell lines are not mixed, so it's not CML. Next up is essential thrombocytosis. This is close, but it's incorrect. In essential thrombocytosis, this is a myeloproliferative neoplasm. Think JAK2 mutation in about 50% of cases. The hallmark is elevated platelets, often over 1 million. So we do have that. And yes, erythromelalgia is a classic symptom due to microvascular platelet clumping. So why is this the wrong answer? And the reason is because neutrophils are elevated. This is indicating a reactive process. So it's not primary thrombocytosis, such as it can be found in essential thrombocytosis. It's a secondary thrombocytosis, also called reactive thrombocytosis. This is due to inflammation or infection. So even though the WBC count is normal, the left shift, aka the increase in neutrophils, is the licensing exam's subtle way of hinting at this. Reactive thrombocytosis can show up with things like endocarditis, where the platelet count can hit around 1 million, but it's not due to that JAK2 mutation. So the key concept that you need to crystallize in your mind for essential thrombocytosis, JAK2 mutation, intrinsic marrow overproduction, as opposed to the reactive thrombocytosis, which is secondary to stress, infection, or inflammation. All right, let's deal with this Waldenstrom macroglobulinemia. This is wrong. This is a plasmacytoid cell neoplasm. Oid means looks like, but isn't. So a plasmacytoid looks like a plasma cell, but isn't a plasma cell. The classic symptom is hyperviscosity. This results in blurry vision, headaches, Raynaud's phenomenon. But in this case, you did not get hypercalcemia, lytic bone lesion, or Bence-Jones proteinuria, seen in multiple myeloma, not in this case. So the patient has no hyperviscosity symptoms and no M spike is mentioned. So The correct answer is secondary reactive thrombocytosis. This is what the licensing exam is testing you on. Do you know that if there is elevated platelets and a neutrophil predominant shift, this is your correct answer? That's the clue that they want you to recognize. So even if your WBC count is normal, there's no fever, this is the subtle signal that you need to be able to pick up on. Now, if they give you a very similar question, but it mentions bone marrow biopsy, but with megakaryocytic hyperplasia, then you have essential thrombocytosis, not reactive. Why? Because reactive thrombocytosis, the platelet count rise is secondary. In essential thrombocytosis, the myeloproliferation is intrinsic. So if you have megakaryocytic hyperplasia, this is textbook essential thrombocytosis. So yes, sometimes infections and essential thrombocytosis can exist, and essential thrombocytosis can present with elevated neutrophils. But megakaryocytic hyperplasia only occurs in essential thrombocytosis, never in reactive. You have to remember this. Now, let's spin the block. If you have erythromelalgia plus thrombocytosis, you have to be thinking essential thrombocytosis or reactive. If the neutrophils are increased, you're thinking reactive. If megakaryocytes are increased on biopsy, then it's essential. Know your differentials for painful red hand. That includes Raynaud's phenomenon, myeloproliferative disorders such as essential thrombocytosis, Waldenstrom, hyperviscosity. You have to remember these. All right, if you like the video. Don't forget to subscribe, and I'll catch you on the next one. Go crush it.